Good afternoon. Thank you for the opportunity to present to you today about person-centered care training, and specifically some methods that are used by the communication group of the Spanish Society of Family and Community Medicine. The Spanish Society of Family and Community Medicine has regional groups across Spain, and the Basque Country Society is called OSACHEN. These healthcare professionals, who are primarily, but not exclusively, dedicated to primary care, family and community medicine, they work in special interest groups, and one of those is dedicated to communication and health. Regional communication and health groups bring together diverse professionals from multiple disciplines, from physicians and nurses and midwives to psychologists. What these professionals all have in common is a passion for improving communication between healthcare professionals and health system users. Through their actions and words, they believe that in order to heal, the healthcare professional must understand the problem and the person. In other words, to be a great doctor, you must understand both these hearts. So this brings us to the question of, can healthcare professionals be trained to better understand the person? And the resounding consensus is yes. We believe, and there's evidence to support, that PCC skills can be modeled, taught, learned, practiced, and mastered. So the Gothenburg Center for Person-Centered Care has some tools and resources available to train the Gothenburg model of PCC. One of these is an application that can be downloaded to your phone or tablet via the Google Play or Apple App Store. You can search for PCC-game in order to download it, and it takes you through a virtual world where you go into situations and reflect on PCC-related questions, hear conversations about PCC and what it looks like in the workplace, can see video clips that demonstrate PCC in action, and also test your knowledge through quizzes. The GPCC also has a tool called Mutual Meetings, and this is a free online course available in English that helps you to adapt and develop PCC. It provides a facilitator's guide, and the facilitator takes groups of 4 to 6 multidisciplinary professionals through 10 structured sessions of theory, exercises, and work. One of the benefits of this tool is that it can be carried out with few means. You need some Post-it notes, a room with a table, and an atmosphere conducive to discussing openly about PCC, what it means, and how it might be implemented. So a place and a time for those meetings. Today, I'd like to talk to you about how we've been training PCC in Spain. But first, let's review again what that Gothenburg model of PCC looks like. First and foremost, it's an ethical standpoint that guides all our practical actions as fellow human beings and professionals. It's a partnership between patients, their relatives, the healthcare professionals, and it's about carefully and perceptively listening to the patient's story and narrative. And it's often combined with the narratives of relatives, and that needs to be documented. And then this all leads to a co-created health plan of goals and implementation strategies and long and short-term follow-up. So in the communication and health group throughout Spain, and the group in Basque Country in particular, we train skills. So it's not sufficient that there's a documented narrative of the patient as a person in the medical record, or that there's a co-created health plan written down in the medical record. Our training is about the interaction of the healthcare professional with the patient as a person and their relatives. And it's about how the narrative unfolds and how the co-created health plan is created. So there are 5 key PCC skills that we have trained. One is about engaging in active listening. So this involves attention to one's own nonverbal behaviors and might include things like eye contact and leaning into the conversation to show interest and encourage conversation. It's also about identifying subtle, nonverbal, or sometimes verbal cues that patients, as people, give off that indirectly express their wishes, their feelings, their goals, and can help move the conversation forward to areas that they may not have explored. So picking up on these cues are important. Another skill that we train is asking open-ended questions and reflective statements that summarize what the patient's been saying and ask for verification if that's correct. This allows the patient as a person to reflect on how they've been communicating and what they've been communicating and what that means, and if the other person has really captured and understood what they've said. And besides open-ended questions, like, and what made you feel that way? Maybe a simple, tell me more, can help open the conversation. And sometimes waiting in silence also helps patients to gather their thoughts and be able to better express and communicate their concerns. The fourth PCC skill is identifying and valuing strengths in the patient as a person. So this might be a statement like, it sounds like you've been going through a really rough time, and I can appreciate how hard it's been for you to come in today and to talk to me about this. Or something like, I really admire your perseverance. The last one is about how to engage in shared decision-making and negotiation that at all times respects and honors the patient's goals and wishes and those of their family. So that brings us to the question of how can these skills be taught? And in our work, PCC is taught exactly as how it's experienced by patients and their families. And this is by experience, not by instruction or informing. And so these PCC skills teaching through workshops requires a skilled facilitator. A skilled facilitator is someone who embodies the PCC ethical perspective. Through his or her actions and words, they model and demonstrate PCC in the workshop with the participants. The session participants are partners with the facilitator. So there's not a hierarchy. Everyone learns from everyone else. The facilitator must be able to create a safe environment where the participants feel that it's okay to make mistakes and to learn from those mistakes, because that is how we learn. And finally, the facilitator should be someone who has the capacity to take advantage of those aha moments that happen spontaneously and really draw out those moments where real learning can occur. And we believe that and can show that facilitation skills can be trained. And in fact, they are trained here in Spain in annual conferences of the communication and health groups throughout the country. We conduct 2.5 to 3 hour skill-based workshops, targeting each of those 5 skills, for instance, in separate workshops. And each workshop involves 3 key components: large group facilitation, small group role play for individual practice, and feedback. So let's go into each of these in more detail. Large group facilitation involves a facilitated discussion by someone with practical experience who, as the participants give comments, they're able to add examples and illustrate and make these skills relevant for routine everyday situations. The facilitators also have to do planning for the workshop to find videos, if they exist, that illustrate those skills that they want to target. And if those videos don't exist, then they may have to create them, develop a scenario, do role playing, and videotape them. And we have a library of these in our archives. Next, the facilitator, once the video is shown, leads a large group discussion on feedback that the participants have regarding the video. They cover 2 main areas. What is the healthcare provider doing effectively to effectively carry out the skill? And what could the healthcare provider do differently to improve his or her effectiveness in that particular skill area? Large group facilitation also involves eliciting from the participants through brainstorming their own experiences where this skill would be valued or in their past experience would have been valuable to better, more effectively handle a given situation. The importance here is relevancy and salience, because these stories and these experiences is what stays in your memory. And when you leave the training, you're going to remember those stories much more than you're going to remember an acronym about how to carry out a skill. So we want to develop that. One of those experiences, one of those relevant situations is selected by the group to develop a case scenario. So all of the details about the situation are discussed and recorded on flip chart. And then this case scenario is what's used for the role play. In small group role play, the facilitator assigns the participants into groups of 2 or 3 so that they can work out what that case looks like in action. One person plays the role of the healthcare provider, the other person plays the role of the patient, and the facilitator goes around the groups and works individually with them and provides them feedback on how they're doing and how to improve and what they've done well, tells them encouraging comments to build their confidence in small groups where it's much easier to feel okay making mistakes. Through that work individually, the facilitator should identify one pair or group willing to present in front of the large group. And once they present their role play, the large group engages in a facilitated feedback discussion. So this also has a structured format where first the role players speak, the healthcare professional gives his or her assessment of his performance, and then the patient describes his or her experience in the patient role during the scenario. And each needs to first recognize what went well and then offer suggestions for improvement. Self-criticism, criticism from the patient, always constructive, and then it's opened to the large group for suggestions. This session then wraps up with asking each individual participant to provide a takeaway or a lessons learned, something practical that they're going to take away from the workshop. Sometimes standardized patients who are actors can also be incorporated into the training. And lots of time this depends on the resources available to you and the number of facilitators available to conduct the training. But when standardized patients have been involved, they are valuable because they're skilled at giving feedback and skilled at rating these skills in the workshop participants. So as the workshop participants go through the series, the workshop and the workshop series, we've demonstrated by asking these standardized patients to give their opinion on how they felt in the role, and we've demonstrated statistically significant skill improvement over time. These patients endorse being able to express their points of view more easily as the session progresses. And they also felt it was easier to speak and explain themselves. And they also felt that the healthcare professional was interested in me as a person. All of these statements endorse person-centered care and suggest that it can be achieved through these workshops. Sometimes we engage external observers to provide a third person, that could be the person number 3 in the small group, to provide an external evaluation assessment of the performance of the role. And when we look at external observer ratings, we also see statistically significant increases in the healthcare provider role. They are better able to grasp clues. These are the nonverbal cues that patients as people use to indirectly communicate their concerns. The healthcare providers were better able to facilitate conversation, to ask open-ended questions, to offer empathy and support. They were more likely to help the patient as a person be able to discover fears and experiences which they may not have considered previously. And they engage in more appropriate use of nonverbal language. So, in conclusion, just as learning physiology or a new surgical technique can be learned. We have evidence that PCC skills can be modeled, taught, learned, practiced, and eventually mastered. Thank you very much for your attention today.